All right, good morning, everybody. There's a lot of excitement in the room, but we're going to go ahead and get started in just a minute. And for anybody who's watching on Zoom, you can run down and grab some breakfast. Join us here because it's quite palpable. All right, so my name is Mary Leonard. I'm chair of the department, and it's my great pleasure to welcome you to Pediatric Grand Rounds. I'll just call your attention on the left here, the QR code and the text codes for CME. And then also to be eligible for MOC Part 2 credit. And then we, as always, point out the upcoming grand rounds because it's always an incredible lineup. And this week is no exception. Next week, we're very fortunate to hear from Dr. Tate with a really extensive case study review on medical child abuse in the perioperative environment. It's going to be an outstanding presentation. And then the following week, I'm thrilled that we have Monica Goyle coming out to give Pediatric Grand Rounds. She is absolutely internationally renowned as a thought leader in health equity, specifically in pediatric emergency medicine, and in partnership with the Department of Emergency Medicine, we'll have Monica visiting us, and we have put together a really wonderful couple days for all of our people who are interested in child health equity to meet with Monica, and of course, hope that you'll attend her Grand Rounds as well. Oh, so you're going to advance, right? Thank you. Okay, we'll do our university land acknowledgement that we sit on the ancestral land of the Muwekma Ohlone tribe. This land was and continues to be of great importance to the Ohlone people. Consistent with our values of community and inclusion, we have a responsibility to acknowledge, honor, and make visible the university's relationship to Native peoples. Next slide. We have a couple of really important announcements. It's getting to be that time, right? Spring is in the air. The weather's beautiful, and that means we're coming up on our spring Pediatrics Research Retreat, the 15th annual retreat. Please register. Michelle Manji is giving the keynote presentation, but it's just a wonderful example to hear from some of our newer faculty, some of our junior physician scientists and postdocs, and it's just really a wonderful day, and really hope everybody can come. And this slide was inspired. I don't think we've done this until now, but we will start doing this whenever we have an endowed lectureship. We have incredible lineups of people that come and speak with us. And so these are all of the folks, and it's quite a who's who in the world of pediatric palliative care that have given the Ben-Efraim family endowed lectureship in pediatric palliative care. And also quite inspired, that's something we'll be doing too, is on the bottom right, there's a QR code where you can scan and learn more about the history of the lectureship. But I think it's really important at this time to acknowledge that Barbara Sorks, who was the John Crewall and Elizabeth Hale Director of Pediatric Palliative Care and established the program in 2001, really was the inspiration behind the creation of this endowed lectureship, and all of the incredible people who have really blessed us and come and shared their wisdom with us are a real reflection of her commitment to the field, and we're very grateful for that. Next slide. There we go. All right, Justin, I think you'll take it from here and introduce today's speaker. Thank you. Justin. Oh, Justin's the chief, the inaugural chief of the Division of Quality of Life and Palliative Care, and there are koalas everywhere.
Yes.
So, okay.
Thank you so much, Mary. We've had such a wonderful time with Dr. Thienprayoon with us these last 2 days. Actually, she's been here even longer, and I know other people have had more fun with her even over the weekend, et cetera. And Emma, I want to acknowledge you as well for being here with us. Dr. Jones, thank you. It's wonderful to be here and have you with us. Dr. Thienprayoon is the Chief Wellness Officer actually at Cincinnati Children's, and she completed her Peds residency and HEMOC fellowship at UT Southwestern and went on. We had a great story. She was the first fellow, weren't you, at Cincinnati Children's in hospice and palliative medicine, which was how she arrived at Cincinnati Children's. She is the chair of the National Pediatric Palliative Care Task Force, a project of the National Coalition of Hospice and Palliative Care, and a member of the board of directors of the Palliative Care Quality Collaborative. In 2020, she was named a Sojourn Scholar on the Cambia Healthcare Foundation. This is a real feather in her cap and an honor. And that group itself is a veritable who's who of pediatric palliative care overall. Her research focuses on measuring clinician experiences of compassion within teams and organizations. And she lives at home in Cincinnati, Ohio with her husband, Paul, and their 2 girls. So she actually will be going home with 2 koalas. And we want to, Dr. Thienprayoon, turn things over to you now, but we also want to give you this beautiful, I mean, this is just so nice. So Ingrid, this is just absolutely stunning. And it is accompanied by another beautiful koala. So
Thanks, Justin.
if we can put it right here, I can package it back up for you. But it's just so nice to have you with us. And we thank you for teaching us yesterday and welcome.
Thank you. Good morning. Good morning, everybody. We made it. Hi, good morning, everyone. What a delight it has been to be here with all of you for the past several days. And thank you so much for coming this morning. I'm excited to talk about my research and also just my passion in medicine, which is clinician suffering and organizational compassion. And I actually need to also comment that I have a family member in the room. My cousin Kate has come this morning. She's emeritus at Stanford, and maybe it's a perfect time to acknowledge that Lucille Packard cared for her daughter through pediatric leukemia. And so we have a very tight connection to your community and so much gratitude for the beautiful care that you've provided to us. My only disclosures have to do with my research funding, and I'm really excited to share them, frankly. My research has been funded by the Cambia Health Foundation, and truly, Justin, the Cambia Health Sojourn Scholar Award changed my life and really redirected the path of my career. So I'm super grateful to them. And my research is funded now by the Ho Chang Foundation. You know, we have so much coming at us nowadays. We have our phones in front of us. We have email. We have worries. We're clocking that we have to go round next and all the people that we're going to be taking care of today. And I like to pause and just say, this is the only time in our lives that this group of people will be assembled for the next hour. And what a gift that is. And so it's to remind myself to just be centered and have gratitude for this. And also just to invite you in as much as you're able for the next 45 minutes or so to be present for this experience with us. And if at any point, any part of the conversation or the talk gets a little heavy and you need to step out, that's perfectly fine. Please take care of yourselves. There are a couple of slides where I talk about clinician suffering that get a little heavy. So the way that the talk is organized, I'm going to talk about suffering and compassion. I'm going to operationally define them. I'll talk specifically about clinician suffering, which is my worry of how we experience the workplace and the work that we do much of the time. And then the answer to it, which I believe is organizational compassion. And then I will weave through the talk themes of palliative care and try to explain how that has informed my approach to this work and continues to inform my approach. So we'll begin with suffering compassion. And I love the lotus imagery for this because Thich Nhat Hanh was a Vietnamese Zen Buddhist writer and thinker and humanist. And he says, the lotus cannot be there without the mud. Likewise, happiness cannot be there without suffering. Looking deeply into our suffering, we gain an understanding of it, which gives happiness the chance to blossom. Thus, the lotus does not have to reject the mud, and the beauty of the lotus actually gives value to the mud. We will never work in a stress-free environment. We care for deeply sick children, and there is suffering in that. And there can also be beauty and immense meaning in it. And so the lotus, to me, is just a really beautiful way of bringing in the idea of without suffering, there cannot be compassion. And what a beautiful part of life compassion is. So what is compassion? Compassion means noticing that another person is suffering, making an empathic connection with the suffering, and then acting to mitigate or to relieve the suffering. So what differentiates compassion from similar states like kindness or empathy, which are feelings, is that you have to act. You actually respond. Compassion is a verb. Without the action, it's simply a feeling, and it isn't compassion. And etymologically, of course, compassion means to suffer with. But I also really love this definition by Chris Germer. Chris Germer is a researcher. He helped develop the self-compassion scale with Kristen Neff. And he says, compassion is when love meets suffering and remains love. And I think this is like the highest form of patient care that we can provide. When we're able to meet our patients and their suffering and love remains love, that's true compassion. So then we have to think about suffering. We invoke the word suffering at the bedside, and we often don't ask really like, what do we mean when we say that word? So I like the work of Eric Cassell, who I learned Justin has spent some time with. And his writings on suffering evolved over the course of his career. So he was an ethicist, a writer, a humanist, a physician who wrote over the 70s, 80s, 90s, early 2000s. And I paraphrase it, that suffering is a state of distress associated with the threat, the intactness of your whole self, your whole person. And the reason I like this is it's not just about a threat to my continued existence. It's not just about physical pain. When my children are sick, I, as a mother, have experienced a threat to my intactness as a whole person. Ergo, I suffer as well. But Another thing you may not know is that when Eric Cassell died, he was described as the intellectual father of palliative care by Susan Block, who's one of the giants in our field. So what she's saying here is his writings about humanism and medicine were pointing out that medicine had become sterile and robotic, and the human being had really been removed from the care that we were providing. And medicine's answer to that problem was to create the field of palliative care. And I'll talk more about that in a second. But Christina Dempsey was the chief nursing officer of Press Ganey, and she wrote a whole book about compassion in healthcare. And she says, you know, suffering is inherent to being a patient. When you're sick, your intactness as a whole person is threatened. And we layer in avoidable sources of suffering for patients and families through the way we deliver care in our healthcare system. And she has expanded this to think about how we as clinicians experience the healthcare system as well. If you read the compassion and the suffering literature, a lot of it stems back to this 2013 report by Robert Francis, published for the NHS, and it's called the Francis Report. And so what happened was there were multiple really serious safety events that happened in the UK over a period of time. And this inquiry was established to understand the root cause of what had happened. And the punchline was the story it tells is first and foremost of appalling suffering of many patients that was not met with compassion at the systems level. The system was not designed to care for them appropriately. The major research regarding patient experiences of compassion comes from Shane Sinclair out of Calgary. Shane's background is chaplaincy, actually, before he became a researcher. And he's published a great deal on what is it about the way that we interact with patients that allows them to experience compassion really profoundly. And he's created this compassion model. And what he says is, you know, the patient brings their suffering into this space, and we bring in embodied virtues and embodied presence. And then through coming to know the person meaningfully and forging a healing alliance, that's the space in which compassion plays out. And so he has created the Sinclair Compassion Questionnaire, which is a patient-reported experience measure of compassion in healthcare. And so if you look at this tool, it asks things that I think we assume we're doing, that we're trying really hard to do, but often we don't actually ask. Did you feel cared about? Did you feel that the person taking care of you knew you as a unique individual? It's things like that. And in order to do this, Shane had to advance the way that we think about compassion, because the historic definition of compassion that I showed you at the beginning, it focuses on the actor. So did I notice that someone was suffering? Did I care? Did I act? Not, did it help you that I did those things? How did you experience it? So Shane is trying to advance our thought about compassion to thinking about it from the perspective of the sufferer. And what he would say, and what I really believe, is compassion that is experienced as competent is really highly personalized. It's based on knowing a person for a long time often. It takes a while to get to know people. And that requires really high quality connections between people. So as I'm thinking about my role as a wellness officer, right, what I'm wondering is, how do I create really high quality connections if an entire team is remote and they're never together? Or over the course of really busy patient care, knowing that I don't want to ask people to come back to work outside of hours, how do I offer social events so that people can really get to know each other deeply and personally without stepping into family time? But understanding what a person needs and responding in a way that is experienced as helpful and compassionate is not as easy as it might seem. But this is what palliative care is designed to do. Our goal is to decrease suffering and improve quality of life for patients and families. So compassion is the very core of palliative care. And it may not surprise you at all to know that Shane Sinclair's work was set almost entirely in hospice and palliative care settings, with the assumption that suffering is high in those settings and that we're designing our care specifically attuned to deliver it. I will talk more about my research later in the talk, but I interviewed 22 pediatric palliative care clinicians of varying roles, and I asked about their experiences of suffering and compassion. And when we designed this study, I have research team members who are really solid management business space folks. And they said, people are not going to have a thing to say about experiencing suffering and compassion. Oh, they had no idea what they were talking about, did they just? Oh, we got so much good data. And so these are just a couple of the quotes from our interviews. I think that the palliative care teams, have an incredible ability to sit with suffering and to sit with things that can't be fixed and to sit with helplessness. This is what we're there to do. We are in some ways unmoored from the responsibility to pick the antibiotic or to choose the next surgery. And I think it's a little bit of a relief, right? We're just there to see them as whole people and to attend to the suffering. And I find that if I am trying to do more than one thing well, if I'm also trying to make the plan for really specific elements of their medical care and take care of everybody else, it's really hard. It's complicated to do both well at the same time. And that's why we need these palliative care teams. We've lost in medicine a lot of the capacity to have those conversations and to create space and to allow doctors to have that space. And yet we somehow still preserve it in palliative care. So how do we do this? We come in a state of non-judgmental curiosity. We're truly just trying to get to know people. How you doing? Tell me about your kids. How'd you guys meet? That's one of our favorite questions to ask people. We get all sorts of good information when we ask them that. We listen to understand, not to respond. This is what we teach our fellows. The secret sauce is we say, what are you hoping for and what are you worried about? What else are you hoping for? Chris Feutner, who's one of the giants whose name was up there, he does a whole beautiful talk on, and what else are you hoping for? People will orient towards hope no matter what we say. The hope will rise up. And we should have a whole talk, if you guys haven't had a talk on hope and how we cannot steal hope. It's such a beautiful space and an important space for us as clinicians. We provide continuity of care. We know people for years and years and years. And over those years, come to know them closer, right? And we say, hey, remember 3 years ago when you were thinking about the G-tube, and at that point, you guys were kind of here in time, and now we're talking about a trach. And at that point, this is why you were thinking of this, and this is where your goals were, and now you're over here. That takes a lot of time. We also do care for other clinicians. There's a really deep relationship between palliative care clinicians and wellness officers. Many of us move into that space at the systems level because we're doing it all day. We're acknowledging the suffering of the bedside clinicians. We're asking how they're doing. We're asking how they're processing. We're adding an extra layer of support for the whole hospital. And then, of course, care within the team is very much a part of how we approach taking care of our patients. We have to be able to take care of each other and take care of ourselves in order to come back and take care of patients. But put another way, Claire Crawford is a pediatric palliative care social worker at Texas Children's. And she did give me permission to show this tweet, but she said, a parent once told me that after so much uncertainty and fear, she had shifted her thinking from what if to even if. It's a concise and subtle change. Anxiety becomes possibility. There's a way forward and a tiny bit of our control back with even if. And I think this is orienting back to hope, right? And that's what we're trying to help families do. So with that foundation, I'm going to talk a bit about clinician suffering. And the National Academy of Medicine did a whole series on well-being and burnout, and part of it was an art exhibit. And so I've used some of the art in my talk with permission from the artists. But I love this one. This one feels like me. I think about all the times that I've come home after a long day and I've taken off my stethoscope and I've taken off my white coat and I look like a lay person, but it's all still with me and I can't shake it. So my dad must have taken this picture from like 40 yards away, Kate, right? I think about in 2003 at my white coat ceremony, what was that girl expecting as a career? I think it was based on like Marcus Welby. It was based on what was even then an outdated model of healthcare, right? I was just going to take care of patients. I wasn't thinking about reimbursement at all. That was like I wasn't clocking that. I wasn't thinking about anti-science and anti-vaccine sentiments in society and how hard that would be. I was just excited to come in and take care of patients. So I had these really, really beautiful expectations, many of which have been met beyond my wildest dreams, but almost none of which were relatively negative. And this is the part of the talk that gets a little heavy, but I was on Twitter for a while, and over the course of 2022, was just sort of gathering direct quotes from folks about how it felt for them to work in healthcare. I've never written this in a chart before. This is not okay. At this point, we're experiencing delays in optimal treatment for this patient due to denial of appropriate medications by the patient's insurance company. These delays will result in a longer hospitalization, higher cumulative steroid exposure, and longer duration of symptoms. So what this person is saying is classic moral distress. I know what treatment my patient needs, and I cannot get it to them, and that is outside of my control. This study will be no surprise to primary care colleagues. To provide all recommended care to a standard sized group of patients would require 26.7 hours each day. It is impossible to deliver the care that we're being expected to provide. We got done with 8 hours of rounding. I sat at my workstation and cried. There's just so much work. It doesn't leave time for us to be human beings sometimes. I just imagine this person who likely had rounded 8 hours the day before and rounded 8 hours the day before and had not had any water, hadn't gone to the bathroom. This month, med students have come in the day a grandparent died, the day of the memorial service, the day of an MS flare, having lost sight in one eye. They don't have time for makeup, so I took my day for interviews. Med students are human too. Why are they treated humanely? Our training has improved a great deal. I'm not pretending that it hasn't, but there's still so many unspoken rules that we're teaching people through how we design medical training. First and foremost, you are a physician. First and foremost comes the patients. I'm sorry about that wedding. I'm sorry about that funeral. You got to work. You are this thing first. And what that teaches us is that our professional identities and our personal identities are so deeply intertwined that when our professional identity is threatened, I think it rises to the level of suffering. And I don't think that that's entirely bad. I am proud to be in such a vocation-driven profession, and I love being a physician, but I have learned these lessons over time. Tell me you don't value your night staff without telling me you don't value your night staff. Dignity is the notion that we all have inherent value as human beings. No one has more or less dignity. It is our birthright. And when you can't eat, when you go to work and there is no food, that's a violation of dignity. I heard a loud noise and ran to see a patient in the waiting room throwing hospital furniture at the resident. The resident got hit by the IV pole, but managed to miss the table. Workplace violence has been a source of suffering and difficulty in healthcare for a long time. And it is worse since COVID. People are not coping well, and that's visited especially in our ER, on our nurses, any high stress environment. And we have been at higher risk of workplace violence from other colleagues for a long time as well. So I think my premise, right, is that clinicians are suffering. And my worry is the literature has moved so far into burnout as like the only construct that we talk about and the only construct that we measure, that the implication is if you're not burned out, you're okay. And if you are burned out, well, then let's do these things, right? But either way, the system isn't culpable. And I think the system is culpable. And I also think we just need more language, because over the course of a career, we have myriad positive and negative experiences. We have protective experiences and we have harmful experiences. And some of those experiences do rise to the level of suffering because our professional identities and our personal identities are so deeply intertwined. I think training can be very dehumanizing. I worry about moral distress. I worry about entering into a for-profit healthcare system when our values are simply that we want to take good care of children. We are at risk of physical and verbal abuse. And we sit in this society that is so polarized right now. And COVID was incredibly difficult, right? We're still in it. That threatens my intactness as a whole person. My sister-in-law is a general pediatrician, and she recommended vaccines to a family. And so they went online and gave her 1 star. And then the company that she works for tried to use that as an excuse to dock her pay. This is the world in which we are sending people to practice. And I mean, on a national level and on a local level, provider autonomy is being degraded actively across our country. And I didn't see any of that coming in 2003 at my little white coat ceremony, right? So I think providing compassion to patients is our collective purpose. This is what we as human beings are driven to do. This is the meaning that we have, right? And our inability to do that causes us to suffer. And I think too, you know, over time, again, showing up for deep human suffering drives us. That is meaning and purpose, right? And so those two balance, because it may have been a difficult day, but we know we did a good job. And over the course of a career, I can balance that. My worry, though, is that now the system is layering in all of these sources of avoidable suffering that have to be mitigated or prevented. And that is organizational compassion. I love to work poetry in usually at the end of a talk, but I thought I might do it here instead. So the Good Listening Project is an organization that just listens. You meet with a listener poet and they say, what do you want to talk about? And then you talk for 10 or 15 minutes and they say, thank you. And a couple of days later, they send you a poem generated by whatever you had to say. Mine is actually about my daughters. So this was written by my friend Jenny Hegland for the Good Listening Project after listening to a nurse. This was my dream as a child, not to work at just any hospital, but to work at this hospital, where my mom was a nurse, where I was born, where I became a mom, where every day I witnessed miracles, supporting the development of the littlest littles, supporting their families during the toughest trials. My roots here run deep, but lately there's no reprieve from the overwhelm, from the overwork, from the need. Too many hats, too many tasks. Can't care well for others. Can't care well for myself. Do I let something fall to give myself a break? Or just keep doing it all for the patient's sake? An impossible choice when I need both to keep doing what I love. And there are some sources of suffering that are unique to palliative care teams too. These really came out during our interviews. Even though I didn't say anything, my presence felt threatening because I was advocating for something that was different than what their plan was. I've had a doctor say like, well, I want this kid to live, so I don't want you to meet them. And I'm like, me too. We don't try to kill our children. A surgeon told my colleague once, you guys just come in and convince people their children should die. There's always going to be something about palliative care that just doesn't sit right with people. It can be hard to be in this space in healthcare, and I suspect it's a bit easier in pediatrics than it is on the adult side, but there are elements of pediatrics that also raise the stakes and make it even more complicated. This is by Joe Rotella, who was just the retired CMO of our Academy of Hospice and Palliative Medicine. But this is what it can feel like sometimes to sit in a pediatric palliative care space. And this is why we have to wrap around each other within the team and take good care of ourselves, because it can be very isolating. So my answer to all of this is organizational compassion. So in the management space, organizational compassion it's defined as trying to cultivate an environment where when people bring normal human suffering in, the response is compassion. Someone notices and somebody responds, right? And Peter Frost was an early writer in this space and researcher, and he said there's always pain in the room. He wasn't talking about the clinic room or the hospital room. He was talking about the boardroom. He was acknowledging that as human beings, we have normal sources of suffering that are just part of our existence. No mud, no lotus. But in healthcare, there are predictable, recurrent, salient sources of suffering for all of us, right? And so we've expanded that definition to say it's proactive, systematic, and continuous identification, prevention, and alleviation of all sources of workplace suffering. So it's not enough just to respond. We must also prevent if we see it coming. Ace Simpson is a researcher in this space, and he's from the UK, and he has this model of organizational compassion. He's the NEAR model, so noticing, empathizing, assessing. You actually make a decision whether you're going to respond or not, and then you respond. And when I'm thinking about how we experience compassion in healthcare, I wasn't sure if that assessment step applied or not. I really was very confused about that. And so as I was reading his literature and thinking about it, that's kind of where my brain was. And I spoke after him a couple of years ago at the University of Michigan. And I was really nervous because this man is a giant in the field of positive psychology. And I was nervous because his work, right? This is very much from the position of the actor, not the experiencer. And he put this slide up and talked about how in the NHS during COVID, everybody would go outside and clap for the caregivers at 7 o'clock. And the caregivers, the clinicians said, don't clap for us, pay us a living wage. We can't afford to pay our rent. We can't afford food. And he appreciated that there was an attempt made at compassion, but it wasn't experienced as compassionate as wrong at all. It missed the mark. And so that was experienced as incompetent compassion. And as we think about experiencing compassion in healthcare, what I didn't want to do was create a tool for an organization to check this list and go, we're compassionate, we did it, get your sticker, right? Because it doesn't matter if people don't experience what you've done as useful and helpful and effective. So I'm not of the mind that compassion is on or off. That was or was not compassionate. It's just you can be more or less compassionate depending on myriad factors. And this is my model of considering compassion in the healthcare space and experiencing compassion. So I think, right, this is the purple box is Shane Sinclair's box. So patients experience compassion primarily from us through our behaviors. And there's a whole body of literature about that purple box. But what predicts how we behave when we're in there? I think it's predicted by our environments. And so I suspect that most of it happens in that pink space. So the team is the primary context in which compassion plays out, because that's where you're most known. And that's where a lot of your suffering will be noticed and responded to. But there are also ways from the green box that this is influenced by the greater context of the organization. Our team's resourced to do this well. Are you given the time to take care of one another? What is the role of RVUs even could be part of this question, right? What is the benefits package? What is the culture? What are the leadership behaviors? So it's not just at the team level, it's also, and then that sits in the greater context of society, which can influence this too. And I would say measuring clinician experiences of compassion specifically and purposefully places the responsibility of the suffering on the system, not the individual. I think self-compassion is critically important. I think self-care is critically important. My ability to do that well is often predicated by my work environment, though. And we have to think about the systems level. It also simply acknowledges that we are human beings moving through the world. We are complicated. We are feeling many things at the same time. And it centers compassion, of course, which is the root of high quality patient care. And, you know, Brene Brown said, compassion becomes real when we center our shared humanity. We had a short center rounds in March, and it was the 4th anniversary of COVID. And we had never at the organizational level acknowledged our shared trauma from 2020 in a meaningful way. And it was fully virtual because we had the auditorium was booked, but that was actually okay because it sort of mirrored our experiences of shorts rounds all through 2020 through 2022, actually. And what I appreciated reading so many comments was people just saying, thank you for recognizing that I'm a human being. I'm so grateful to work in a place that acknowledges my humanity. That feels like a really low bar, honestly, but it's hard to do sometimes. So what did we do? These are our scientific methods. We began with a scoping review of the literature just to understand what is the state of knowledge, what is the evidence for organizational compassion in healthcare. We only found 2 papers from the US out of the 16 or so that met our criteria, and it really pointed directly towards shorts rounds as an intervention. And then, as I mentioned, we interviewed pediatric palliative care clinicians, analyzed them qualitatively. From those data, we generated our items. So we started with about 800 direct quotes, and then over the course of several months, moved those quotes into items that could be measured. And that we then ran a candidate set of items by some clinicians. At that point, we spread out to pediatrics more broadly in a modified Delphi just to see how are they landing. So what we found in that stage was positively worded items were landing better than negatively worded items. And we cut a couple just based on the responses. And then for our next set of candidate items, so at this point, we're at about 48, we actually sat down with pediatric clinicians of all roles and said, you know, when I say I felt cared about, what does that mean to you? To understand if our wording was right and where we needed to improve things. And this was where we went deep on team versus unit, leader versus supervisor versus manager, and phrases like that. And then we are now in preliminary reliability and validity testing phases. So if you see a recruitment email, please consider being part of our study. We're recruiting pretty broadly from across pediatrics. The domains of experiencing compassion. So when we organize those items that we have, they fall into certain buckets, right? Not surprisingly, feeling cared about is part of experiencing compassion. But what's new to the literature is dignity. Dignity has never been raised up as part of compassion or suffering before. And so dignity, again, it's just the idea that we have inherent worth and value as human beings. So those quotes are about things like feeling valued as a clinician, feeling respected, feeling that you're able to speak up and that your voice is heard on rounds. The relational or proximal compassion is the thing that it's the way it plays out in teams. So feeling that the people with whom you work closely notice and respond to your suffering, you're comfortable asking for help, you receive help when you ask for it. And then structural or organizational compassion is like, is the system designed to do this? What are your benefits packages? It's questions like that. And then finally, compassionate leadership behaviors. Do leaders understand what people need? Do they respond when people raise up problems? Is the organization willing to change for the better or not? And is there congruence between espoused values of the hospital and how you see your leaders behave? Because when we experience hypocrisy in that space, especially as clinicians, we have a very, very difficult time with that. And it interferes with our ability to experience compassion. So specific items, I thought you guys might want to see like kind of where we're leaning. So in feeling cared about, I feel that my team cares about one another's individual needs. Dignity, my organization values its people as people, not just as workers. When I'm distressed, I'm able to debrief with someone on my team. These are the kinds of questions that are falling into these buckets. And there's some overlap in the domains. It's not perfect, but we're trying to create like a holistic set of items that really get at all the important elements of experiencing compassion. So learnings and surprises, that assessment step is real. We are judging how people behave towards us all the time. And if we judge their motivations as authentic and genuine, then we experience compassion more genuinely. If we judge that they're behaving not because they care, but to check a box, then we experience it as lower compassion or even to the level of suffering. And that was really surprising to me and I think is really fascinating. Dignity is fundamental to experiencing compassion because it goes back to our humanity, right? And then if you are deeply burned out because of the cynicism aspect of burnout, that's also a barrier to experiencing compassion. So again, as a wellness officer, I worry that I have a group of people who I need to move out of burnout enough to then get to the next stage, because while you're so deeply burned out and you're just reacting to every threat that's coming your way, it's really hard to experience authentic and genuine compassion from around you. But my ultimate goals, right? I want to understand how the way we experience compassion predicts how patients experience compassion. I want to understand how we experience compassion predicts burnout and other outcomes in the workplace. But ultimately, I just want to create compassionate systems for clinicians in order to help us create sustainable careers in which we're able to thrive and really bring meaning and purpose to work at every day, feel like our highest and best selves at work every day, and have energy outside of work to be the people that we want to be and do the things that we want to do. But I'm also trying to, again, like expand our lexicon of the way we talk about clinician experiences in the workplace beyond burnout or not burnout, beyond engagement, which it's important. This is what the organizational folks think about, right? They think about engagement. Over the course of a career, we have myriad experiences and our language is really limited and we have got to expand that. And then for the next, just the end of the talk, the last 5 minutes, I'm just going to talk a little bit about, okay, well, that's all great, Rachel. Like I have to go to work today. How do I operationalize any of this? So thinking about the clinician level, the team level, and the organizational level, we went to Gatlinburg a couple of years ago and hung out with friends, and it was wonderful. And I had actually had a call with my coach while I was there, and she said, "You look 10 years younger in the mountains." So yeah, we need to take our vacation. We need to unplug while we're on vacation. My ability to do that is directly related to my system, though. And did I have my schedule far enough ahead of time to make this plan to go do this thing? Am I reimbursed in a way that allows me to take vacations from time to time? So I don't like to focus too much on this. Other people do this space really, really well. This isn't my space. But just to say, my self-care, my ability to sleep without interruption, whether I'm able to eat during the day and go to the bathroom, do all these things, those are not on me entirely to sort out. For compassion in the team, we're teaching and spreading the stress first aid model throughout Cincinnati Children's. Stress first aid is a model that was developed by Patricia Watson for the Department of Defense. It was actually developed for EMTs and paramedics and veterans who work in really high stress environments. And it provides a way to check on one another. That sounds a lot like noticing. And the teaching of stress first aid says, you're not just surveying, you're not just checking, but when your radar is going off and you know people aren't well and they say, no, I'm fine, take a moment and double click. And then it gives you language. You know, I've noticed XYZ. This doesn't seem like you. How are you? give them a real opportunity to talk about how they're doing. And then it gives you these other steps, just really practical ways in the moment to say, okay, I think you're stressed for this reason, and these are the things that I can do to help you. It's a flexible model. It's easy to implement. It's easy to reinforce over time as you teach it. And if you guys belong to the Short Center, it's free. So we went through the Train the Trainer program as part of our Short Center membership, and then we can spread it however we want. So this is one of the big pushes from the wellness program this year, is to begin to share these skills throughout children's. This is the palliative care team at Cincinnati Children's on a retreat. We shot each other with rubber arrows. It's really therapeutic. Not very good at it, which is not therapeutic. So how do you cultivate meaningful connections in your team? How do you find and create space to really get to know each other when you've got a list 60 patients long and you come in knowing I got to get through all of this over the course of the day? But we do that. We share the workload. We are constantly debriefing. We're working it in between patients, right? These are things that palliative care teams are taught to do and do very purposefully. We prioritize debriefs. We sit down monthly and we run the list of patients who have died, and we grieve them and we remember them and we acknowledge that loss. We acknowledge that suffering and we move on. And over what period of time? Some patients are harder than others. But we normalize self-care. We normalize going to therapy. It's normal on the same day. I'm going to therapy today. Okay, great. And the system is built to give me time to do that, right? And then on a leadership level, there has to be accountability for toxic behavior. Teams can't function. One person can really throw everything off. And so this is where leaders need to know about it and need to respond. And then, of course, the realistic workload. We can't have sustainable careers if there's always too much work to do. And then in the organization, Children's became a pilot site for the Healing Healthcare Initiative, also through the Short Center. This is designed for the system leaders. So this is our COO, our CEO, our CNO, our chair of Peds, CHRO, and they went through trauma-informed organization training. And my role as wellness officer came directly out of HHI. So leaders have to think about these things too, and the Short Center offers an opportunity to do that. But again, congruency between espoused values and behaviors is really important. The perception that leaders genuinely care about the front line. And our research is that we have realistic expectations. Our expectations of our team leader are not the same as our expectations of the chief of staff or of the CEO, but we do expect them to have an awareness of what's going on at the front line and design a system to help respond to it. What is your capacity to bring forward the voice of the frontline folks, to raise it up and to change for it? That's all part of compassion in the organization. So this is my research team. I got some ringers here, you guys. I am so lucky to work with these guys. Beth Lown has informed this work. Jason Kanov is one of the OGs in positive organizational psychology and organizational compassion. Todd and Adam are psychometricians. Teresa is actually now a PhD. She finished her dissertation and moved from a CRC role into a big girl job. Eli is positive organizational guy at the University of Cincinnati. Naomi Winnick is a pediatric oncologist at UT Southwestern and just my long-standing research mentor and the most compassionate clinician I have ever met. And then Shane advised throughout, and John C. is our primary CRC. So I'll leave you with a couple of quotes. What I regret most in my life are failures of kindness. These moments when another human was there in front of me, suffering. And I responded sensibly, mildly, reservedly. Responding sensibly can feel easier in the moment. It really can, especially if you're strapped and you're stretched and you're tired. And we have to normalize knowing where ourselves are, knowing where we are in order to take care of the people around us. And then finally, our human compassion binds us the one to the other, not in pity or patronizingly, but as human beings who have learned how to turn our common suffering into hope for the future. Thank you. I'm so happy to take any questions. I know Justin's got one.
I do. I was looking online as well. So people that are online, please go ahead and put them in the Q&A. And so, Rachel, thank you so much. That was just fantastic. I wonder, and if this is too personal, please don't do this, but I wonder if you'd just highlight kind of your path and what really inspired you to move this direction in your career, and kind of speak about that in the context of being a palliative care clinician and being just a human.
Mhm. I think deep human suffering has always been a space where I feel like my highest and best self as a physician. And that's what took me into pediatric oncology, and that's what took me into palliative care. And in 2016, I was home on maternity leave with my first baby, and I got a phone call from a guy named Raj Basu, who is now chair of critical care in at Lurie Children's, and he was in charge of Schwartz rounds. And he said, "Hey, Rach, I want to pass this off, and I think you'd be good at it. Do you want to be the physician champion of Schwartz rounds?" And I said, "Yeah, thanks, great, you know." But sitting in the rounds and listening to stories of suffering from around the organization, I just appreciated this one event is really important, but it is insufficient to meet the needs of all of these people. We have got to think about this at the systems level. And some of the other Schwartz rounds leaders and I, over the years, started building towards what is now the wellness program. And the woman who brought Schwartz rounds to Children's is now the senior director of wellness. So there's always been a really deep connection to the work of the Schwartz Center. And then I read a book called How We Work by Leah Weiss, who's here at Stanford, actually, in the business school. And it changed the way I thought about our organization. I read the Book of Joy by the Desmond Tutu and the Dalai Lama, and it changed the way I thought about compassion and suffering. And then the reason Cambia is such a huge piece of this is I sat next to Steve Panelat at a lunch, and he asked me what I was interested in, and I said, "I got this interest in compassion, and I don't really even know what it is." And he said, "Well, that's your Cambia project. You should write for a Sojourn Scholar Award." And I said, "It'll never work." But a pandemic hit, and I was at home thinking about research, thinking in the quiet, and I pulled the grants together, and they funded it. And that allowed my whole career to really shift in this very specific direction. So I have experienced tremendous compassion from people I wouldn't have guessed. If you said, "Okay, who do you think is going to be really compassionate to you in the next year?" I don't even know if I would have thought of these guys, but I got very burned out in 2022. And the people who noticed and checked on me were a pulmonologist who I've worked with for a long time. He saw me in the PICU and he said, "You're not okay. What's going on?" I said, "I'm fine." And I ran off. And then he came to my office the next day and said, "Sit down. What's going on? You're not yourself." And the same thing happened with one of our anesthesiologists, just a senior pain doc. He saw me in the hallway and did a double take and said, "Let's go to your office and sit down and talk." And I experienced those moments as profoundly compassionate, and I had felt very disconnected, and it started to heal, you know, how I was. And so, yeah, that's how I got here.
Thank you. Someone else. What do you do when nonprofit healthcare system, when a nonprofit healthcare system, when a nonprofit healthcare system is acting as if it was a for-profit healthcare system? That's why I was having a hard time flipping that around, where the healthcare priorities are actually causing much of the stress that's going on.
It's a leadership question. I think it's really hard on an individual level to fix the system. And I spent a lot of time volunteering in wellness spaces and trying to like lean into spaces like this, and I burned myself out. So I think that's a question for organizational leaders to think about. And right, we have to do this at the individual level, at the team level, at the leadership level. And so this isn't someone that at the individual level. The way that I manage it is sometimes I focus my attention away from that, and I focus on the really beautiful care that we're trying to provide to patients and families. And I try to notice those things instead, and orient myself to spaces of beauty and hope and meaning, because I have finite energy, and I'm not a senator. I'm not a lobbyist. I'm not a person in that space. I think Children's has over the years really evolved in how they allow us to advocate as clinicians. And that's really important, because when we were not allowed to use our voices and speak up about what we believe is right or wrong, that was experienced as suffering. And so having leaders over the last few years and watching how they've evolved in public spaces on social media, what they're saying has given us permission. Patty Manning did this. Ohio has passed the bill making gender affirming care there's specific parts of it. I don't know the exact language, but basically making it illegal. Patty Manning, our former chief of staff, was very clear where she stood on this on social media. She was at the State House. Our chief of staff, our CEO testified to defend children. That also helps me, right? Like, what are we doing? Because you and I've talked about this a lot. In the absence of information, we tell ourselves a cynical story, sometimes an ungenerous story when it comes to our leaders. And I think leaders have a responsibility to close that gap. There's so much that happens that nobody ever knows, right? And I see it as a wellness space I told you, like, I want to create a podcast, an internal podcast for children's folks, where I can just have the leaders come and tell the folks directly, like, hey, yeah, that we are working on this. You know, we hit #1 in the country. And the way that was experienced by so many of our clinicians was, oh God, no. Oh God, we don't have enough doctors for the influx of patients we're going to have. I'm exhausted just thinking about this. Yeah. And that story was never filled with the truth, which was, no, we know what to do. This is the ways that we're mitigating that. This is the way that the system is anticipating and responding to that. But nobody knew, because we don't filter that information down. So I think some of the answer also just has to do with bridging that gap, closing that gap. And, you know, like on Monday of last week, we released the Mayo Wellbeing Index. This was a huge milestone for me this year. Okay, we're gonna start measuring. And I was clinical and I went to my team and I was like, did you see the email? And they all went, no, we deleted all our emails this morning. What are you talking about? Okay. That's not the right way to communicate. It's one way to communicate, but we need to be really creative about meeting people where they are and not just using this one form to try to reach everybody, because it's not as effective as we want it to be.
That's great. I wonder also, yesterday you did such a beautiful lunch and learn. Would you speak a little bit about the impact of this work on quality overall and kind of how, you know, I'm thinking specifically about almost the 5 domains or 5 areas as you described them yesterday, and this is a different audience. So I wonder if you'd just speak to that briefly.
Yeah, so when the wellness program came into existence, in addition to pulling in short center rounds and peer-to-peer and these support structures, it was also raised up as a quality domain. So I physically sit, in the Anderson Center, which is our quality and safety center. I sit next to the chief safety officer. And right around the corner are the chief access officer, the chief PFE, patient and family experience officer, and the chief outcomes officer. So those are the 5 quality domains: safety, access, patient and family experience, wellness, and outcomes. And the relationship between safety and wellness is really profound and really important. And so I have said to the space people, like, if you have to move us, you have to keep the wellness officer next to the safety officer, because when there's harm, there has to also be healing. And our organization was ready, I think, like when they bought into wellness, that's why they positioned it that way and really elevated it to drive for impact. But that means that I've been at the table throughout the course of the year thinking about this and answering questions and coaching sites of care on how wellness should be measured in their site of care, what interventions we need to do to improve wellness. And given that we have constrained resources and very specific organizational goals, it's like, well, safety drives wellness. If we don't have additional resources for this, if you're in a site of care that people are experiencing physical harm, start with that, because that's going to drive wellness, right? Optimizing access, flow, and capacity, especially capacity, will drive wellness. So it's baked in now in a really big way that, like I said, it's been a little overwhelming, but it's also been really gratifying.
Thank you, Rachel, for a wonderful talk with so many thoughtful themes that for us to think about. What I want to offer to you is, if I think about this as an issue of policy, politics, and funding, and I wanted to put it together as a package, how can you promote it, and how can you really cover those bases to have it become more successful?
Policy, politics, and funding. At the federal level or at the organization level?
Wherever you want to start.
In terms of policy, and I'll think on the organizational level because it's a little easier to start there. Well, okay, actually, I would say in terms of politics, I think it starts with the individual. My therapist says, limit media exposure and do good works. And so as I watch polarization and deep divides develop, I worry that what we're doing is dehumanizing one another. And we have to actively stop doing that. So from a politics point of view, my approach has been live in the space I am in, appreciate actively that we are all whole human beings with complicated pasts. Don't reduce one another to good or bad. And that plays out in organizations too, right? Because we want to tell ourselves story about our colleagues sometimes that are really ungenerous, and not founded in a full understanding of what is motivating them. So for me, on the politics front, it's been a lot of really active, intentional behavior changes so that I don't feel like I am reducing the people around me or the people on the other side to the worst potential version of themselves. In policy, I think Children's has really specific values, and the leaders acknowledged that in order to continue to live those values and take care of our people, they needed to invest in the wellness program. So it requires an acknowledgement of the importance of this work and funding it, resourcing it, not just checking a box again, but really investing in infrastructure to allow our workers to be whole people, and thinking carefully about what are the sources of stress, distress, suffering that are modifiable, because not all of it is modifiable. We will always work in an incredibly stressful space, and then actively seeking to remove or change those areas. Funding, there is clear ROI on wellness work. Retention is you guys know, right? We have a crisis of staffing. This work helps retain, it decreases turnover. We lost so many profoundly knowledgeable nurses during COVID, right? And that's a safety problem. It's not even just about funding, it's about safety. We had to take a step back and stabilize before we can build. But I think the ROI is there. And that was the story I told when I came. It wasn't the story I had to tell. It was the story that I was, sort of prepared to tell. And it goes deeper, right? Because it also means that boards that govern who the leaders are have to think about this too. So what I think is really beautiful about this is that it does play out at all these levels, at the individual level, at the team level between people, at the organizational level, as we think about structuring an organization in a certain way, and then in the public sphere. But the public sphere is ultimately just us, isn't it? So it goes back to the individual level. Maybe that wasn't as operationally clear as you would have liked, but it's a complicated question.
It's just great. Dr. Thienprayoon, thank you so much. It's wonderful to have you with us. I want to also say it's so great to all be here in person. I mean, this is fabulous. Those of you online, we welcome you and are glad you're here. But this room is filling up a little more each week, it feels like. And so it's wonderful to be here. And thank you so much, Rachel, for your contribution. This has been unbelievable. And I hope everybody has a great day.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.